back for the session of success T. So success is the surest way to achieve success in critical care exit exams. So that's what we call the success, and stands for theory. So we are here to give a very quick brush up for the possible questions that can come. Last 2 years we had been doing this. This is the third year. First year it was little unorganized, I would say, very organic, and but next year we did a fantastic. We had close to 83% of questions coming from what we also suggested. It was extremely helpful to the candidates, and our intent is not to teach you. So I would be very, very clear both to the faculty and the participants that our intent is not to teach you in details, because you can't have so many questions covering up and all others. And the other point is that you are more than informed than us, because you are preparing yourself. 3 years you have studied, only a couple of months remaining for the exams, 1.5 months remaining for the exams. So this module would be, we will have 12 modules, and this course would be very quick brushing up. That's why each question that we will cover in 8 minutes, and then another 2 minutes to if there are any questions, or we will the expert faculty as well as the lead guide faculty will give some anecdotes on that part. What we will also do is that we would be sharing you good articles itself, very precise review articles for each and every question, so that if you wish, you can read from that. As well as we have also committed that we will be sharing the PPTs too, so that you can read from that itself. You will also, we have yet to decide whether we will have the uh, online video recordings, because we wanted you to come live, so that you put your effort as well as put your concentration to read about it. So I will also request that even if you are working, I know this 24 hours of uh, overall content, it is very difficult. You guys are anyway working and all others. So I will say that you can put your earplugs or earphones, and you can carry on with your individual work and listen to it on that part. Whatever you are listening, it would be helpful. And the idea also is that in this 10 questions you have to write in 180 minutes. That means approximately roughly 15 to 16 minutes. So in 15 to 16 minutes, whatever the best points you can write, we will be presenting in that way. So that's the idea on that part. So we have 12 domains. You must have seen that. Today we would be starting on with the trauma and obstetric critical care itself. And to present, I will invite the guide faculty, Dr. Vijay Anand, and Vijay will introduce the faculty, the presenting faculty, and also himself. So he has got a long list of achievements itself. So over to you, Vijay.
Thank you so much, sir. Thank you so much for the kind introduction. So we have got three faculties with us. So we'll be presenting on the important aspects, questions with regards to trauma and obstetric critical care. So first we have Dr. Pradeep Kumar, who has finished his DRNB critical care from Columbia, currently working as a consultant at Apollo Hospital, Madurai. So, and there is one more faculty, Dr. M.S. Manoj, who has a general medicine background, who has done his DRNB critical care. He is in charge of an ICU at Madurai, Rio Hospital Specialty at Madurai. And the third faculty will be Dr. Abhinaya. She is DRNB trauma anesthesia, sir, and she'll be speaking about the trauma components. So shall we start with Dr. Pradeep, sir?
And I forgot Vidur is also there, Dr. Vidur Joshi.
Yes, I just
please introduce.
Yes, sir. And we have got one more guiding faculty, Dr. Vidur Joshi is also with us. Welcome, Dr. Vidur Joshi. So there are 10 questions which we have been trying to deal with obstetric critical care as well as the trauma critical care. So to begin with, I'll invite Dr. Pradeep Kumar to start with this presentation on the 4 topics which are very important with regards to trauma. Is that okay, Pradeep?
Yeah, hi, sir. Hello.
Yes, yeah.
And to all the presenters, kindly stick to the time. That's the most important aspect.
Yes, sir.
Okay, thanks.
Yes.
Can I share the screen, sir?
Yes.
Yeah.
Able to see my screen, sir? Is it okay?
Able to see your
Hello?
screen. We are able to
Yeah.
see your screen.
So good evening to one and all. So quickly, I'm going into my topic. My first topic is about skin and soft tissue infection. So skin and soft tissue infection is the third most common cause of sepsis. It can manifest varies from superficial infection to life-threatening necrotizing fasciitis. So we can divide the skin into epidermis, dermis, superficial fascia, subcutaneous fat, deep fascia, and muscle. On that, if the infection involves superficial fascia, we will call it as cellulitis. If it involves below superficial fascia involving subcutaneous tissue and deep fascia, we will call it as necrotizing fasciitis. Even in this image, we can see this subcutaneous tissue is supplied by very good blood supply. So this necrotizing fasciitis can easily spread from one part of the surface to the other very easily without involving the background skin. And these are the very valid clinical points because these patients may get very sick even if we delay hours in ER or ICU. And necrotizing skin and face tissue infection is kind of surgical emergency where they have to be operated, resuscitated, and antibiotics has to be started as early as possible. So other clinical points, most common organism causing skin and substitution infections, gram-positive organism, especially beta-hemolytic group A streptococcus is most common, and it's seen very high incidence in diabetic patients. Staph aureus, including MRSA, also most common, even though it can come from community. It is most common associated with abscess and commonly seen in IV drug abuse. Gram-negative is less common in case of skin and soft tissue infection, but it is associated highly in case of cirrhosis patients where Klebsiella E. coli are commonly seen in neutropenic patients, Pseudomonas aeruginosa. In case of immersion injury, special kind of where we can see a Vibrio vulnificus or Mycobacterium manium or and Aeromonas. And this is the classification of necrotizing fasciitis where they are divided into four types. Type 1 is polymicrobial, where it associated with diabetes, immunocompromised peripheral vascular disease. Group 2 is monomicrobial, group A streptococci or MRSA. Group 3 is Vibrococcus vulnificus, and group 4 is fungal infection. And the important point about discussing about the skin and soft tissue infection or necrotizing fasciitis is that scoring system where there is a scoring system called laboratory risk indicator for necrotizing fasciitis, which was originally invented by Wang et al. If the score is more than 6 to 7, there is intermediate risk. If it is more than 8, there is high risk of developing necrotizing fasciitis. This is a modified score where they have included clinical parameters along with RBC count and fibrinogen levels. So quickly coming to the signs and symptoms, yeah, in any coming to any theory exam, it's very important to write the clinical features and clinical presentation. Most commonly, this presents with the local signs and symptoms and the background history and the time duration. All this history is pertaining to the disease is very important. Coming to treatment, skin and soft tissue infection and necrotizing infection, surgical emergency, and imaging shouldn't delay the process when obvious clinical signs and rapid progression of the disease is very important. And goal is to perform aggressive debridement with all necrotic tissue till healthy tissue, viable tissue reached. Where bleeding, we can see the active bleeding. For severe and worst case scenario, amputation may also be needed. Coming to antibiotic therapy, in general, we try to cover the empirical antibiotic coverage should include broad spectrum antibacterial activity, including gram-negative and gram-positive. For gram-negative coverage, so in any ICU scenario, the antibiotic choice should be dependent upon certain factors, which including the presentation of the patient, how sick their patient is, and possible susceptible source of infection, whether it is UTI, whether it is skin and soft tissue, whether it is lung, or whether it is CNS infection. Depending on that, our antibiotic coverage should be there. And severity of the patient, whether there is any possibility of MDR organisms. So these are the certain factors which depend on choosing antibiotic therapy when coming to ICU scenario. In skin and soft tissue infection, if the patient is very sick on inotropes, very sick, where it's rapidly deteriorating, it's always go ahead and put higher antibiotic therapy with piptas or carbapenem depending on the severity. In gram-positive coverage, we use vancomycin or daptomycin. Alternative to vancomycin, daptomycin is linezolid. Clindamycin is most commonly used for its antitoxin effect against especially beta-hemolytic streptococci. And obviously, other organ support, fluid resuscitation, IVIG is upcoming, but there is not much evidence. And hyperbaric oxygen therapy, this comes later in monitoring such patients. So once we can obtain culture, if we have Clostridium or strep then penicillin plus clindamycin. If penicillin allergy, then we can go for vancomycin, daptomycin. Staph aureus, MSSA means oxazoline or cefazoline. If it is MRSA, then best drug of choice is vancomycin. If it is Vibrio cholerae or Aeromonas, you should always add doxycycline in the background. And in any clinical scenario, clinical question arises, there are certain headings which should be there, in which one of the most heading is differential diagnosis, because it implies our clinical knowledge. When we add this differential diagnosis in our theory exam, and even the DRNB question paper, they specifically ask the from erythema, edema, warmness due to venous obstruction, inflammation. It is associated, which we should include in our theory writing exam. The most clinical points includes when patients with necrotizing fasciitis have pain disproportionate to the clinical findings. The early stages of necrotizing fasciitis, apparently there will be normal looking skin, but underneath that good blood supply is there, so the bacteria keep on spreading to the other one part of the to the other. And Lernick score, which we discussed before, should include delay in diagnosis and surgical intervention leads to increased risk of mortality and morbidity. Communication and teamwork between intensive surgery, anesthetists, and microbiologists are essential in identifying the organism and treating the organism at a very early point. Coming to compartment syndrome, yeah, it is more likely which we
Pradeep?
see surgical trauma. Hi, sir.
Pradeep,
Hi, sir.
we are going to talk with the necrotism fasciitis, or this is the second thing? You will.
This is the second question, sir.
Second question, sir. Arindam, sir.
Yes, we will very quickly sort of summarize. I like the way Pradeep presented it along with the key points itself.
Yes,
Very
sir.
nicely elaborated on the score. At times, in the last point, if you see that disproportionate to the physical findings, we actually emphasize more on the diagnosis, maybe that the MRI related, because that gives you the extent and also gives a idea to the surgeon for the overall what would be the extent of surgery itself and the planning.
Yes.
I like the way you also emphasize the use of clindamycin and doxycycline in specific situations, advantage of clinda, and also at what way you are using doxycycline. Daptomycin is a very good, in fact, maybe I would prefer daptomycin on that part, but for exams, you have to write both vanco and daptomycin itself. And last point, that communication, teamwork, and the intensivist has to take the major role in coordinating the entire day. Everyone wants to avoid, the surgeon defers, the anesthetist put up all sort of problems on that part, then sending the samples itself and all others. And in the differential, you can actually, the candidates, you won't get time to write so many detailed differentials, but differentials has to be given and it can be ruled out with your clear-cut imaging and certain investigations. Vijay, you want to add anything?
Nothing, sir. Nothing. Everything has been covered, sir. So we do kind of first to do all these things, sir. Anything more, you can just. Yes, sir.
Anyone, Vidur, you want to add anything?
No, sir.
Okay, fair enough. Pradeep, let's go to the next question.
Yeah, sir. My second question is compartment syndrome, which we most commonly seen in surgical ICUs or orthopedic patients, where in definition, if any pertaining question comes, they specifically ask for definition. So it is increasing osteofacial compartment pressure. Compartments are group of bones, muscles, nerves, and blood vessels in upper limb and lower limb. It is divided into specific compartments, and each compartment is covered by fascia respectively. So the delta pressure less than 30 between diastolic pressure and facial pressure indicates compartment syndrome. I'll explain it later with better diagrams and pictures. So what are the causes for causing compartment syndrome? It can be divided into internal causes and external causes. So in any case, when you give any etiology, it's always better to give a broad category first and then subcategories below the broad categories. So in internal causes, it can be hematoma, coagulopathy, fracture, overexertion of muscle in case of seizures, post-ischemic deprivation injury, especially animal bite, snake bite, soft tissue injury, vascular injury, DVT, and idiopathic. External causes includes circumferential cast or dressing, burns, scar, military anti-shock trousers, and compression from prolonged immobility, especially in case of orthopedic cases where we have seen cases where they have tied the tourniquet for a prolonged time, which can lead to compartment syndrome and later lead to multiple complications related to compartment syndrome. So what is the pathophysiology of compartment syndrome? Whenever it comes to pathophysiology, it's better to put some bar diagrams over it rather than writing theories. So it can cause intrinsic cause, extrinsic cause, which leads to increase in compartment pressure. The increase in compartment pressure leads to decrease in the arterial pressure and increase in the venous pressure, due to which there is a capillary blood collapse and increase in edema, causes decrease in tissue perfusion and tissue death. So this is the most clinical signs which we talked in the bedside, where you can see pain, pallor, paresthesia, paralysis, pulselessness, and pykothermia, which is hypothermia on touch. So delta pressure, for diagnosis of compartment syndrome, we use specific pressure called delta pressure, where we can see tissue intramuscular pressure and diastolic blood pressure. If the delta pressure is less than 30, means the diastolic blood pressure and tissue intramuscular pressure is less than 30, it implies compartment syndrome. If intra-compartment pressure is more than 20 with hypotension, it implies compartment syndrome. Interrupted arterial perfusion for more than 4 hours also been considered as a compartment syndrome. Compartment syndrome associated with long bone fractures, it can cause 6 Ps. This is another diagram which specifically implies the same things. Coming to treatment, majorly includes decompression. In case of cast bandage, the things should be completely removed. Limb is nursed flat, and delta pressure should be less than 30. To maintain that, we immediately open the fasciotomy and decrease the compartmental pressure. Fasciotomy should be done in all sides. All facial compartments should be opened up. For example, in leg, all 4 compartments, medial, lateral incision should be opened up. If there is any muscle necrosis, debridement, patient should undergo debridement. If the tissue is healthy, we can later suture the wound or skin graft. That's about the compartment syndrome.
In compartment syndrome, do you do a sort of measure the pressure itself? Because striker has a small needle
Small
itself.
needle, yeah, needle.
The needle itself, which can infect a lot of people. So that can also be mentioned, that you can monitor the compartmental pressure with the striker needle itself, right? And it can be easily calibrated, as well as sort of we can do it in our monitor itself. So that gives you a good idea of the delta pressure itself. And urgent, do you have any time frame for doing the bedside fasciotomy? And most of the time, the fasciotomy is done at bedside itself. Many of these people would have a little bit of coagulopathy. So that correction of coagulopathy, and there is you have to emphasize increment of the diastolic pressure, because that also determines your delta pressure. So so correction of coagulopathy, increment of the diastolic pressure, these two factors are also to be considered. Vijay and Vidur, please comment.
No, sir. It's already prepared, sir. That's why, sir. We have taken all the things and included, sir. Yes, sir.
Okay.
Yes, sir. Shall we go to the next question, sir?
Yes.
Yes.
Okay.
Next.
So this in next part, mostly I discuss about the secondary ARDS, where ARDS secondary to any other syndromes, especially TRALI, trauma or fat embolism syndrome. And I would like to touch upon the each individual topic. So when it comes to TRALI, what is TRALI? TRALI is a clinical diagnosis. It suspect TRALI when the new acute injury develops during or within 6 hours of transfusion, where the patient gets every criteria of ARDS and develops within 6 hours of transfusion. We should include TRALI, and we have to rule out other factors of ALA such as sepsis and aspiration. TRALI has been associated with all blood components that contains plasma. Even though all blood products have associated to known to cause produce TRALI, most important is the plasma, and transfusion of every even part 1 unit has been associated with TRALI. And coming to the newer definition of TRALI, it's a serious potential fatal complication of blood products in which patient develops rapid onset lung injury and non-cardiogenic pulmonary due to activation of immune cells in the lungs. What is the mechanism of injury? Various mechanisms are yet to be known to cause TRALI. Includes microaggregates in stored blood causing micropulmonary emboli and lung damage. But in theory, has been discredited multiple theories, including antigen antibody hypothesis, 2 event hypothesis, patient underlying condition, cytokine storm, genetic predisposition, and endothelial cell injury. What is the difference? There are two types of trolley, trolley 1, trolley 2. Trolley 1 is without any predisposing causes for ARDS, we call it as trolley 1. If there is any predisposing cause for ARDS, along with the transfusion will lead to lung injury, when we call it as trolley type 2. Who are at risk of trolley? Age, female sex, tobacco use, chronic alcohol use, positive fluid balance, any shock before transfusion, ASI score more than 1, and mechanical ventilator patients are potential risk factors for developing a trolley. And coming to TACO, one of the most common differential diagnosis for TACO. What is TACO? TACO is defined as more similar any all qualifying ARDS criteria along with any 4 symptoms which occur within 6 hours of transfusion, especially acute respiratory distress, increase in the blood pressure. Increase in the blood pressure is one of the most important differentiating point which differentiate between trolley and TACO. Tachycardia, onset of the disease within 6 hours, and exaggeration of acute pulmonary edema, which can be verified by X-ray if possible, and a positive fluid balance. Difference between TACO and trolley transfusion reactions. With both, patients present with respiratory distress due to acute onset pulmonary edema. With trolley, patient also can have hypotension and fever, whereas with TACO, one would typically have hypertension and lack of fever and leukopenia. Coming to the next thing, fat embolism syndrome. What is fat embolism syndrome? Due to long bone fracture, fat globules enters into circulation, and it causes typically 3 things, includes hypoxemia, neurological abnormalities, and petechial rash. This is a symptomatic diagram where due to long bone fracture, fat globules enters into the circulation, which can cause hypoxemia due to lungs, and due to skin involvement, it can cause petechial rash and neurological involvement. Even though these 3 are more pronounced, other various organs can be involved, including bladder, kidney, liver, ophthalmic presentation, temperature, cardiac, myocardic presentation, and various blood levels, increase in the blood markers, biomarkers. Coming to the pathophysiology of fat embolism syndrome, it can be divided into mechanical or biochemical. Mechanical is due to the direct fat embolism, direct embolism of this triglycerides, whereas biochemical is due to this triglyceride breakdown or free fatty acid breakdown. It produces various factors including like glycerol, free fatty acid, all which can trigger various kind of reaction in various different organs, from brain encephalopathy, lung ARDS, skin petechial rashes, renal, oliguria, heart, RV failure, MI, and eyes, it can cause retinopathy. So to diagnose fat embolism syndrome, we have GERD criteria, we have major criteria, minor criteria. Major criteria includes petechial rash, respiratory infections, cerebral involvement. Minor criteria includes fever, tachycardia, retinal changes, jaundice, retinal signs, thrombocytopenia, anemia, and ISR, and fat microglobulinemia. Sorry, so in any kind of secondary ARDS, the treatment is always supportive. For fat embolism syndrome, there is no definitive treatment for fat embolism syndrome. We have to treat the cause. We have to fix the fracture as early as possible until the clinical, whenever the clinical window appears. For trolley and TACO, for trolley, we have to stop infusion. We should stop further transfusion and ventilator and other supportive management. Especially for TACO, we can use diuretics, ventilation, and elective monitoring. Once stable, transfusion can be initiated slower at later rate. Sir, this is done.
Yes, I think there's fantastic presentation on that part. Trally is a very important and both the types has to be. There are a lot of pathophysiological understanding in the trally itself, why it happens, why it is predisposed in certain way, and there are certain types. So I have just put a very nice article on that. I'm just putting it in the group, but in very details of trally is also there. So you may not have to read the entire thing. Just read the overall quickly, pass through it, you will have a very clear idea on that really itself. And treatment of trally again is more of a ventilatory management and also anything you wanted to add, Pradeep, on how to prevent trally itself, leukoreduction, filters,
Yeah, sir. We
irradiation.
can use leukoreplicated platelets or irritated.
Actually, there are we can even use combination of both
Combination of
irradiation and the leukodepletion. And
platelets.
leukodepletion, please read about it. It can be done during collection or when you are actually giving a transfusion itself, right? So both this can help on that part. Regarding fat embolism, particularly during the reaming process, as you are told, with the high pressure and others, it can go. And wherever there are small capillaries, it will get stuck on that part. And if you have a PFO, it can go to the central circulation, arterial side of that part itself. At times in the early 2000, we have used alcohol also, IV alcohol itself, but it didn't give that a. Now it is symptomatic management, mostly anticoagulation, supportive care, and all others. People do get better, and also brain with multiple. If you have a PFO sort of a, there could be a multiple infarcts in the brain itself, fat embolism sort of a. Anything, Vijay and Vidur?
No, sir,
Please.
no, sir, no, sir. We have prepared everything, sir. That's why we ordered, sir. Yes, sir.
I think yeah, that part has to be. You please add while you are submitting that
Yes,
how
sir.
you can prevent trally itself.
Okay,
And
sir.
is there any predisposition to recurrence? If someone has got trally once, does that? But I'm not sure about the answer. So you look into it
Yes, sir.
and
Yeah,
add,
sir.
please.
Sure, sure.
Thank you. Please carry on.
Yes, sir. So coming to my third question will be post-surgical complications in ICU. So in this part, I divided three. When it comes to major GA surgery, anastomotic leak recognition and management. So when coming to post-surgical complications, intestinal anastomotic complications are associated with increased patient mortality and morbidity. And these most common complications pertaining to intestinal anastomosis includes minor bleeding and major bleeding, dehiscence and leaks, strictures and fistulas. Postoperative management of surgical patients itself a very big topic and very different topic. In this, I just want to focus more on this anastomotic complications, especially dehiscence and leak. So dehiscence and leaks, overall incidence anastomotic leaks is 2 to 7% when performed, even when performed by experienced surgeons. The lowest rates are found in ileocolic anastomosis 1 to 2%, and highest occurs in coloanal where it can occur 10 to 20%. Most anastomotic leak usually becomes apparent between 5 and 7 days postoperatively. Lake leak often presents insidious with low-grade fever, prolonged ileus, non-specific symptoms attributed to other postoperative infectious complications. Small contained leaks present later in the clinical course may be difficult to distinguish from postoperative abscess by radiological image, so making diagnosis uncertain and underreported. So clinical signs, pain, fever, tachycardia, peritonitis, fecal drainage, purulent drainage. These are the bedside clinical signs which can directly lead us to the dehiscence. Radiographic signs include fluid collections, gas containing collections, and intraoperative findings. Obviously, there will be entire spillage with anastomotic disruption. Even though when you are writing in clinical, you can write it this pain, fever, tachycardia very simply, but at the bedside, it's very difficult to diagnose whether this patient have undergone anastomotic leak, especially in the earlier critical care phase, where patient will be having a ventilator, they will have line. So fever can be pertaining to any line sepsis or it can be any VAP. So it is high clinical suspicion and high degree of suspicion should be there. And especially when it comes to surgical patients, we never know what the surgeon have undergone or what or how they have repaired inside, whether there is any gangrenous bowel was left over. So all these details has to be included while dealing such patients. Coming to management, ICU always supportive management. If there is any dehiscence or any leakage, obviously patient has to undergo surgery. So our major idea is to support the patient, resuscitate the patient for the major surgery, where we are typically go for intravenous fluid resuscitation. When it comes to fluid resuscitation, comes of bowel surgery, ventricular fluid should be used, and more we can use albumin and broad spectrum antibiotic coverage. With if patient stability permits, then best is to go for radiological image, where we can do CT scan with oral or IV contrast or rectal contrast, and it helps in the part of where the dehiscence is there. With management strategies including observation, bowel rest, percutaneous drainage, colonic stenting, surgical revision, diversion, or drainage. If there is any free intraperitoneal leak is demonstrated, then patient should undergo taken to operating room for surgical management, as I explained. Patients who present with generalized peritonitis or high-grade sepsis with hypotension should be resuscitated and brought to operating room for exploratory aptotomy on emergency basis. These are the major things which we tend to deal in case of anastomotic leaks when it comes to ICU. And my next
I think one is your this regarding your diagnosis,
yes,
oral, rectal, and IV contrast, what we call the triple contrast, could be a good A. Second is your stenting is a new option, but at times very difficult
right.
to put the stent on that part, diagnose that exactly where. So surgical revision and diversion with laparoscopic way, if the patient is stable enough to undergo a laparoscopic, we do that a lot of so that is part. You haven't mentioned about the nutrition. What would you do on this, Pradeep?
Sir, when it comes to nutrition part, we, even though the guidelines says should not jump on treating the nutrition, yeah, if we are person is not going to get bowel fed for more than 72 hours, then we should consider early TPN.
I would ask Vijay and Vidu to comment on this.
Yes, sir. There are no specific guidelines for regarding the nutrition part, sir. But what the Pradeep says is the earlier TPN will be a good option in the patients who are not able to feed immediately, sir. Hello?
Fair enough.
Yes,
I
sir.
think you should mention for exam purpose, you should mention 3 to 5 days because enteral nutrition would be very difficult and all others. The other things is that, did you mention the risk factors for anastomotic leak?
No, sir. We didn't include in that thing, sir.
So please include that the risk for particularly your albumin, your then your intra-abdominal pressure, prolonged surgery,
Sir,
again
the
nutritional
personal taken of the
deficiencies and
patient.
all
Yeah,
others. So
yeah.
kindly include this part also. Okay.
Yes, sir. Yes, sir. Yes, sir.
Okay. Thank
Yes,
you. Chalo.
yes.
Thank you, sir. Next comes to post-esophageal respiratory complications. When it comes to esophageal surgery, these are high-risk patients, and pulmonary complications are more common in such category of patients. And pulmonary complications includes causes more severity, morbidity, and it can approximately incidence up to 30%. The most common complications include pleural effusion, atelectasis, chylothorax, pneumonia, pulmonary embolism, and respiratory failure. Major risk factors includes diabetes, pre-existing lung disease, FeV1 less than 65% of predicted value, low serum protein, blood loss, and volume, how much volume of blood transfused during surgery, advanced age, history of smoking, general performance status of patients, and inadequate postoperative analgesia and stage of the disease. These are the major factors which define whether the patient is at risk of developing respiratory complications or not. Patients who had undergone upper esophageal tumor had 3.5 times more risk of developing pulmonary complications when compared to patients with lower one-third esophageal carcinoma. So upper esophageal carcinoma patients undergoing surgery have high risk of developing pulmonary complications. Just images of most common complications where we can see effusion with collapse and empyema. These are the most common complications for imaging a place. Coming to management, mostly prevention is better than cure. So when we are taking for post-esophagotomy, we should expect certain degree of patients where they can develop such complications. So the most important is to optimize such patients before taking for surgery, which includes smoking cessation, preoperative pulmonary rehabilitation with incentive spirometry, meticulous operative techniques, judicial fuel administration, yearly extubation whenever it is possible. Just delaying things won't work here. And use of post-operative epidural analgesia, good analgesia where the patient can effectively cough out the secretions, and yearly use of extubation and yearly use of HFNC in case of pulmonary diseases, type 1 respiratory failure, aggressive pulmonary toileting, and maintaining head end of basin in elevated position, and careful evaluation of post-operative swallowing. These are the major things which we can help in preventing the post-operative esophagotomy complications. And whenever pertaining to the patient develops pertaining complication, and management should be dealing more on that pertaining complication. And next is post-pancreatomy complications. So pancreas has been always defined as the most unforgiving organ in human body, owing its to its desperate location and numerous important neighboring structures, which are most of them are vascular, leading to pancreatic surgeries are most typical surgeries. And most common complications of pancreatic surgeries include delayed gastric emptying to bowel biliary leak, post-operative pancreatic fistulas, and post-operative pancreatic hemorrhages. I want to discuss more detail on post-operative pancreatic hemorrhage, where the International Society of Pancreatic Surgeries have graded this post-operative pancreatic hemorrhages into 3 grades. grade A, where the hemorrhage occurs yearly, where it can be intraluminal, extraluminal, where it is mild. Grade B is early, intraluminal, extraluminal, where it can cause severe. Grade B is late and it causes mild. And grade C is late, which is always very severe. So this is the difference, where depending on the clinical presentation can be mild and severe and can divide into very early or late. Coming to management, when the patient have early post pancreatic hemorrhage within 24 hours, if it is mild, then obviously it's not life threatening and we should go opt for non-operative management. When it is severe with large volume blood loss, hemoglobin drop of more than 3, clinical deterioration with invasive treatment requiring reoperative angiographic embolization, then these patients are high risk patients and should treat aggressively. Coming to late post-pancreatic hemorrhage of more than 24 hours, it is divided into mild, severe, and hemodynamically unstable. If the patient is mild category, then best is to undergo CECT image, identify the part of bleeding where whether it is due to any pseudoaneurysm or not. And it is severe, if it is have to rule out whether it is intraluminal or extraluminal. If it is intraluminal, then most common of developing post-operative pancreatic fistula, where interventional endoscopic, laparoscopic based surgery and there is no post-operative pancreatic, then we have to do interventional angiography. If it is extraluminal, ICU care and CECT, and try to identify the causes of bleeding. In case of severe variety, where we have some certain window, the best treatment is to go for involve in IR, interventional radiology, and go for interventional angiography. If the patient is very hemodynamically unstable, then we have to go for emergency laparotomy. Sir?
Sir? Arindam, sir?
Coming, sorry.
Yes, sir. Yes.
Now, very nicely present, Pradeep. All the way were the exact way we wanted. Regarding the post-pancreatic hemorrhage, your pancreatic hemorrhage, if you can please add the etiopathophysiology of those both luminal and extraluminal, intraluminal and extraluminal. At times, it could be also certain pseudoaneurysms too. So that is in the I think that could be on the late phase of post-pancreatic hemorrhage itself. Angioembolization is now the most important how you do along with endoscopy itself. Though we will discuss in the pancreas, in the hepatopancreatic domain, I think we have certain questions on surgical management of pancreatitis itself. Regarding esophageal A, I think most of them were covered. I will ask Vijay and Vidu to comment, then we move
Yes,
to.
sir. Yes, sir. We have covered most of the things, sir. So anything you like to add, sir? I've added all the things in the slide, sir.
Vidur?
I think POPF or delayed hemorrhage, splenectomy has a role, if I'm not wrong. Maybe that can be included in the management part. Hemorrhages which are not controlled, splenectomies do have a role.
And how does it help on that splenectomy? Because it can bleed from the splenic artery, or what?
Sir, actually, what I've read and what I remember very distinctly is that the hemorrhages, when they are severe and the patient is going on the downward slope, so the surgeons are not able to very easily get
Right. Let's move on.
Yes, sir.
Yes, sir.
Introduce the next speaker.
So Abhinay will be doing the questions on assessment of polytrauma patients, lethal damage control resuscitation, traumatic brain injury management. You can start, Abhinay. Yeah.
So, good evening, everyone. So,
Can you share the screen? Your screen is not shared.
I'm sharing my screen. It's not visible, sir.
No, you are only seen. Can you share the screen?
No, Pradeep has to
Pradeep, you just
unshare.
log out, no?
No, he has to unshare.
Stop.
Now he
Is
can.
it visible, sir?
No.
Vijay, kindly tell Pradeep to give these three articles. That would be
Yes,
very
sir.
helpful.
Yes, sir. Manoj,
One on
stop sharing your
anastomotic
screen.
esophageal lay, and the other last one is on post-pancreatic hemorrhage.
Okay, sir. Yes, sir. Yeah. Abhinay, we are able to see now.
Okay, sir.
You
Yeah.
have to do a full screen.
Full screen, Abhinay.
Yes, sir.
Yeah. You can start.
So, coming to polytrauma patients, so where to start and how to assess? So, a patient coming with an RTA history, sustained injury to head, chest, abdomen, and with signs and symptoms like complaining of abdominal pain and bilateral lower limb. So, where to start? So, here comes our ATLS approach. Primary survey, secondary survey, and adjuncts to primary and secondary survey, and establishing the need for once AB. So what that? So primary survey is nothing but it's targeting trauma prioritize sequence. What are the life-threatening traumatic injuries like tension pneumothorax, open pneumothorax, mass action? Even importance, there is external to be taken in a control of exam hemorrhage threatening being direct packing tourniquet and airway important, yes, and all airway maneuvers has to be done with cervical spine restriction. So coming to breathing and ventilation part, just not only ensuring the patent airway, we have to ensure adequate oxygenation and ventilation. So the life-threatening injuries which are to be treated here is tension pneumothorax, massive pneumothorax, like with the use of immediate ICD, chest decompression. So circulation and next part C, circulation with hemorrhage control. So the first step is here is to identify whether patient is in shock. And next, where is the source of hemorrhage? And controlling the source of hemorrhage and with simultaneous volume resuscitation is important and for more. So some of the agents which helps in ECG, pulse oximetry, and capnography, and serial blood investigations like ABG, CBC, lactate, and two X-rays like chest X-ray and pelvic X-ray, and two tubes, urinary catheter and gastric catheters. So when to start secondary survey? Once the primary survey is completed, if the patient is stable or if the patient has been responding to the resuscitation, then comes the secondary survey. So the role of secondary survey is to identify all injuries. So it starts with brief history, ample, allergies, medication, pregnancy or past meal, last events, and head-to-toe evaluation. Have head-to-toe evaluation from the head to the toe evaluation, detailed evaluation, and specific diagnostic tests like CT scan and other bone X-rays we can be included in this. And we have to serially and reassess the vitals and everything, and we have to check for all the missed injuries. So at the end of secondary survey, we need to determine whether the patient can be taken care of here or in the particular center, or the patient has to be transferred to the definitive care center. So now we're coming to lethal diamond. So there once it was a lethal triad, hypothermia, acidosis, coagulopathy. This combo, each other even it aggravates one another. So this combination, it increases the mortality. Now hypocalcemia has been added. One second. So hypothermia, it can result from any deranged thermoregulation, or it can be due to fluid resuscitation or skin and body cavity exposure to the surrounding environment, where the temperature is less than 35 degrees Celsius. Hypothermia per se impairs coagulation and platelet function. So acidosis, particularly when the pH is less than 7.2, it impairs it worsens coagulopathy and reduces the myocardial performance. It is also an independent life-threatening risk factor in life-threatening coagulopathy in massive trauma patients. So coming to coagulopathy, trauma per se causes coagulopathy. It is not only due to shock or dilution effects of crystalloids, or due to the contributing effects of hypothermia and acidosis. It is also due to the trauma causing increased activated protein C, or causing hyperfibrinolysis. Especially in traumatic brain injury, it is also documented that the release of tissue factor into the systemic coagulation, it also aggravates coagulopathy. So hypocalcemia, so calcium, which has an important role in coagulation, cardiac functions, and several enzyme activations. When it is low, it has a massive effect on the mortality. So ionized calcium targeting up to 1 to 1.2 is essential. So hypocalcemia is like when ionized calcium is less than 1 millimole per liter. So shall I go to next? Yes, first.
Harinam, sir?
Yes, I think more or less most of the things were covered, and also control X, A, B, C, D, E, as well as uh, your uh, what are the sources of A. We could have easily added a focus on this part, right? Maybe it could be a separate question on that. In fact,
Okay.
maybe you can add a couple of one slide and make it a little or comprehensive itself.
Okay, sir.
Anything, Vijay, on your side?
No, sir. No, sir. No, sir. We'll add up the focus and add it to the slides again. Yes.
And in fact, focus could be in an a full-blown question itself.
Yes, sir.
Okay.
Yes. Yeah.
So coming to the second part, damage control resuscitation. So we have seen the lethal diamond. So the most important approach to prevent this lethal diamond is damage control resuscitation. So what is that? It's a group of strategies, a core principle which has been evolved into a standard of care in treating the critically ill patients, which addresses the lethal triad or diamond. Usually it was initially coined, this damage control concept was initially coined by United States Navy system, where they prioritized the critical repairs needed to return the ship safely to the shore during the maritime emergency. So damage control resuscitation, it includes main three components: permissive hypotension, hemostatic resuscitation. So that is nothing but yearly balanced blood product resuscitation while minimalizing the crystalloids, with the simultaneous efforts to achieve the rapid bleeding control using damage control surgery and to prevent or correct coagulopathy, hypothermia, and acidosis. So permissive hypotension, it's nothing but targeting a low systolic blood pressure of around 80 to 90, which thereby avoiding the exacerbation of hemorrhage by hydrostatic clot disruption. Meanwhile, at the same time, we are maintaining the adequate end organ perfusion. So the main contraindications for this permissive hypotension is elderly and patients with traumatic brain injury, where higher systolic blood pressure is targeted. So how are we achieving this hemostatic resuscitation? Yes, yearly administration of PRBC's plasma platelets in a balanced ratio to minimize the excessive crystalloid administration. It improves the patient survival. The most promising trials like Proper Study and PROMIT trial, which came in 2013 and 2015, they found that these patients achieved the earlier hemostasis, especially this Proper Study, which showed that 1:1:1 group combination who received of ratio of plasma platelet PRBCs, they achieved hemostasis very earlier, but there was no significant difference in mortality outcomes. So we have to simultaneously we have to limit the crystalloids. According to ATLS recommendation, initial rapid infusion of 1 liter of crystalloids in adults, and in children the recommended bolus is around 20 ml per kg. Because the large volume crystalloids, it causes dilution of coagulopathy, hypothermia, and acidosis. Vasopressors can be used as a temporary measure to maintain the tissue perfusion when the resuscitation is in progress. So adding to this is massive transfusion. It is nothing but a institution-specific protocols. Many institutions to ensure a rapid fixed deliveries of this balanced ratios. So when we call it as massive transfusion, more than 10 units of PRBCs in 24 hours, or more than 4 units of PRBC in first hour, or replacement of entire blood volume in 24 hours, or loss of half the blood volume in 3 hours. So some of the predictors which are used to estimate the need for massive transfusion or ABC score and TASH score. And so adding to this damage control resuscitation, we can use this goal direct resuscitation, where rapid viscoelastic tests like ROTEM can be used for guiding the resuscitation of this coagulopathic and massive bleeding patients rather than the fixed ratio of blood products. Again, this whole blood, low titer group O whole blood is now increasingly being recommended as an option in DCR. But the problem is its availability and the paucity of large randomized trials. So coming to tranexamic acid, according to the CRASH2 trial, there's been a promising result. So administration of 1 gram of Tranexa over 10 minutes, followed by the infusion of 1 gram over 8 hours. If the patient has come within 3 hours, it is within the 3 hours of injury, then it is beneficial. It has a good mortality benefit. So fibrinogen, cryoprecipitate, prothrombin complex concentrates can also be used. And recombinant factor 7A, it's not routinely recommended, but it has been used as off-label use in severe trauma cases with significant bleeding, particularly when the conventional treatments are insufficient. And it has been also noted that it reduces the transfusion requirements. So calcium, targeting a ionized calcium of around 1 to 1.1 is recommended using calcium chloride or calcium gluconate. And usually it is said that for every 4 units of PRBCs transfused, calcium can be supplemented. And also serial ionized calcium monitoring is needed. And in patients who are on anticoagulants, so reversal with appropriate agents has been recommended. And in special populations like pediatrics, geriatrics, their particular physiology has to be taken care of. And coming to temperature control, maintain the trauma temperature, operation room temperature of more than 26 degrees Celsius, and warm fluids and bloods to more than 37 degrees Celsius with fluid warmers, and may ensure the core temperature of about more than 36 degrees Celsius. So finally, the last component, the damage control surgery. It involves 3 phases. First, the initial phase is the controlling of life-threatening hemorrhage and contamination. Next, the patient will be taken into ICU, where where we are continuing the resuscitation and correcting the physiological derangements once the patient is stabilized, and then they can be taken again into the definitive management for the injuries. So some measures like abdominal packing, vascular shunting, endovascular shunting are usually preferred. So endpoints of resuscitation. So when can we see like the resuscitation is complete? So not when the physiological parameters like vitals and urine output is normalized, and biochemical parameters like lactate normalization, base deficit, IL-6, everything has been normalized, then we can then we can ensure that resuscitation has been adequate.
Yes, finish the damage control, sir. Arindam, sir.
I'm listening to it. Only, I think you have also given the dosage for fibrinogen, cryo, and all others. In fact, there is a separate question for reversal of NOACs or anticoagulants, any of the anticoagulants itself. Emphasis on angioembolization, which is a very, very important aspect. And also, you have covered good with the surgery. I think more or less everything covered. And anything you guys want to comment, Vijay, Vidur?
No, sir. No, sir.
No,
Vidur?
sir.
Yeah.
Covered, sir.
Fair enough. Please carry on.
Okay, sir. Shall we go to the next question? Abhinay, next question, Abhinay.
Yes.
Yeah, traumatic
So
brain injury.
coming to traumatic brain injury. So first we'll see about the physiology. So due to the high O2 demand and high cellular oxygen consumption, so the brain is more vulnerable to ischemic injury. And something about cerebral autoregulation. So cerebral blood flow is autoregulated and maintained constant when the mean arterial pressure is between 60 to 160. And outside this range, it becomes pressure dependent. So cerebral perfusion pressure is equal to mean arterial pressure minus ICP. The normal value is around 80 to 100. So coming to molecular doctrine, any increase in total volume of the cranium is fixed. So any increase in one of the component will be compensated by reduction in either of the other two components. So when this compensatory mechanism fails, intracranial pressure rises, then leading to reduced cerebral perfusion pressure and risk of herniation. So this cerebral perfusion is directly dependent on MAP. So any rise in ICP will compromise the cerebral perfusion and cerebral blood flow. So acute intracranial hypertension is defined as sustained increase in ICP greater than 20 millimeter mercury for more than 5 to 10 minutes in a patient that is not being stimulated. So coming to traumatic brain injury, where primary injury, it occurs occurs at the time of contact to the head and brain as a result of initial incident. So secondary injury, it results from either systemic or intracranial process, like systemic process like hypotension, hypovolemia, hypoxemia, hyperglycemia, any other things, or any other intracranial process which occurs at the moment of injury, or it starts after the clinical course. So the primary goal in treatment of traumatic brain injury patients is to prevent secondary brain injury. So classification of traumatic brain injury, it is based on severity and morphology. So based on severity, mild, moderate, severe. Mild with GCS of less than GCS of 13 to 15, moderate with GCS of 9 to 12, severe traumatic brain injury with GCS of 3 to 8. So morphology based on skull fractures and intracranial lesions like focal or diffuse. And coming to imaging based classification, we have Marshall CT score and Rotterdam CT score. So Rotterdam is more recent advanced, which takes into consideration of basal cisterns, midline shift, EDH, and subarachnoid hemorrhage or intraventricular hemorrhage. So how to approach and manage the patients? Severe traumatic brain injury patients, initial resuscitation as according to the ATLS approach, it's ABCD. And so once the patient is stabilized, then we can proceed with CT scan. So GCS less than 12 is always an indication for head CT, as more than 80% of the patients will have injury. So in patients without LOC, or any post-traumatic amnesia, we can consider CT if the patient is GCS is less than 15, age is more than 65, or if there is any coagulopathy or with focal neurological deficit, severe headache or vomiting, with signs of basilar skull fracture, or with a history of ejection from the motor vehicle, pedestrian struck or by a motor vehicle, or fall down from 5 stairs or more than 1 meter. So, and based on the CT file, is when to go for surgery. So, acute SDH with thickness of more than 10 millimeter, or with midline shift of more than 5 millimeter, any size. Any size, if associated with GCS of drop of more than 2 points, or if there is associated asymmetric non-reactive pupils, and EDH with volume of more than 25 ml, thickness of more than 15 millimeter, or midline shift of more than 5 millimeter, or with a GCS less than 8. And cerebral contusion with GCS of less than 8, or midline shift of more than 5 millimeter, or associated with the signs of herniation. Cerebellar hemorrhage like posterior fossa lesions, any lesions with diameter of more than 3 centimeter, associated with any mass effects, brainstem compression, or hydrocephalus. So these are the optimal value targets required in the management of traumatic brain injury patients. So coming to Brain Trauma Foundation guidelines, management of severe traumatic brain injury patients. So DECRA and rescue ICP, based on those trials, the decompressive craniotomy is not recommended to improve the outcome, but it can be used large bifrontal frontotemporal parietal decompressive craniotomy is recommended as for a late refractory ICP elevation. And prophylactic hypothermia is not recommended generally, and hyperosmolar therapy is not there's no sufficient evidence to support the recommendation, but it is effective in control of the raised ICP. Continuous CSF drainage is effective in reducing the low ICP, especially in patients with GCS of less than 6. So prolonged prophylactic hyperventilation is not recommended, but it can be used as a temporary measure for reducing elevated ICP, and especially it has to be avoided during the first 24 hours. And Coming to analgesics, anesthetics like high dose barbiturate, it can be used for refractory ICPs. For refractory ICP elevation, which is refractory to medical and surgical management. And steroids, which is a level 1 recommendation, it is not at all recommended. And nutrition, which is a level 2 A recommendation, like achieving the basic requirements by 5th day or 7th day is recommended. And the infection prophylaxis, use of providone in oral care is not recommended. Early tracheostomy is recommended to reduce the ventilatory days. And DPT prophylaxis, LMWH heparins can be used in combination with mechanical prophylaxis, but there is insufficient evidence to support the preferred agent or dosing or time or dose or timing. So coming to seizure prophylaxis, which is a level 2A recommendation, phenytoin, in case of preventing, it is not recommended for the prophylactic use for preventing late post-traumatic seizures, but it is recommended to decrease the incidence of early post-traumatic seizures. So blood pressure. So we have seen about treatment. So now coming to thresholds. So there are 4 recommendations regarding this. So blood pressure threshold, maintaining a BP of around more than 100 in the age group of 50 to 69 and more than 110 in the age group of 15 to 49 or more than 70 years. And targeting ICP of less than 22 when treated once when it is more than 22 is recommended. Cerebral perfusion pressure to be targeted between 60 to 70, and cerebral monitoring threshold, jugular venous oxygen saturation of around less than 50% can be kept as a threshold. So intracranial pressure monitoring, it's recommended finding, and also in a patient even with a normal CT scan, if there is associated posturing signs, systolic BP of less than 90, or if the age is more than 40, it is recommended. Cerebral perfusion pressure monitoring is recommended and to decrease the 2-week mortality, and jugular bulb monitoring is usually recommended. And coming to ICP management, so first is to identify whether there is features of any raised ICP. So immediately initiate urgent measures and can initiate ICP monitoring. As seen, so in comatose patient with severe traumatic brain injury with abnormal CT findings or with a normal CT findings with more than 40 years of age and posturing, ICP monitoring is recommended. So invasive monitoring, non-invasive monitoring, both are there. So invasive monitoring, the most common anatomical sites used are intraventricular, intraparenchymal, subarachnoid, and epidural. And intraventricular monitors are considered as a gold standard. Non-invasive monitoring with the help of optic nerve sheath diameter, pupillometry, EEG, NIRS, transcranial Doppler, and radiological findings using CT and MRI ICP is possible. So coming to ICP monitoring, ICP waves. So ICP waves, it is usually produced by the pressure transmitter from the arterial pulse to the brain. It has 2 waves. It has 3 waves, which is P1, P2, P3. P1 is nothing but it represents arterial pulsation. P2 represents brain tissue complex, which is of most importance in our monitoring, the traumatic brain injury patients. And P3 represents venous outflow. So normally this P1 is more than P2 is more than P3. If P2 is more than P1, it suggests the reduced intracranial complaints, which implies that brain is stiff and it's less able to accommodate the volume. So coming to Lindbergh waves, A, B, C. So Lindbergh waves, A is pathological, which is nothing but it's a periodic sustained increase in ICP for about 5 to 15 minutes. And it is usually associated with the poor complaints, poor prognosis. And Lindbergh B waves and C waves are self-limited increase in ICPs which occur every 2 to 4 minutes. And they are normal. So coming to ICP management, so tier 0, the basic supportive measures like proper adequate analgesia and sedation, and targeting a saturation of more than 94, cerebral perfusion of more than 60, intubation and ventilation. And tier 1, if the ICP is not reduced, if it is more than 22, then we can escalate to the tier 1, where where we target the lowering the ICP using escalation of sedation and analgesia and normocapnia of around 35 to 38 and EVD and hyperosmolar therapy. So hyperosmolar therapy using mannitol and hypertonic saline. And then if still the ICP is high, then escalate to tier 2 where the target hypocapnia is around 32 to 35 and we can consider trial dose of neuromuscular blockers. And finally, if it is still persistent, if it is still refractory, then barbiturate, coma, mild hypothermia, and secondary depressive craniotomy can be ensured. Thank you.
I think it was a very comprehensive review on that part, your brain, particularly on this primary, secondary. I would also say that intracentral pressure monitoring, both invasive and non-invasive, could be a full question itself. Particularly non-invasives are on the rise. So you please read about it. I think we have given on a detail itself. Brain Trauma Foundation recommendations are at the last moment. You just read the bold letters. Otherwise you won't be able to remember the most important aspects. You have to you cannot write that entire thing. And management of your intracerebral raised intracranial pressure in a tired approach, it has to be, and you have a strategy to make your the tires itself 0, 1, 2, like that itself, so that you can quickly represent very nicely on that part. And obviously this would be also important in the practical, so we'll discuss later during the success P itself. Vijay and Vidur, please.
Nothing to add from my side, sir.
No,
Vidur,
sir, it is good, sir. It is crisp and good, to the point.
Okay.
Okay, sir. Next, shall we go to the next topic, sir?
Yes, please.
Okay.
Thank you, madam. Very
Yes.
nicely done.
Abhinay?
Thank you, sir.
Yeah. Okay. Abhinay, stop sharing your screen so that Dr. Manoj can start his presentation. Dr. Manoj?
Yes, sir.
Okay. Can you share your screen? Yeah,
Am I audible, sir?
You are audible. You are audible. Can you share your screen?
Yes, sure, sir.
Okay. Dr. Manoj will be presenting on the obstetric critical care, like eclampsia, dysfunction pregnancy, critical care obstetric hemorrhage. These are the 3 topics he will be covering. Undo it. Okay, I'm doing just now. Is the screen visible?
Yes, sir. Visible, sir.
Okay, that's for full screen. Manoj, you tell me whenever you want to change the screen, I'll change. Okay, to start.
Yes, sir. So, I thank Dr. Vijayan, sir, and Dr. Adnanda, sir, for presenting in this forum. So, I will be covering on the obstetric side. So, the first topic will be preeclampsia. So, next, sir.
Yeah.
Next slide.
Yeah.
So, the topics covered here will be definitions and diagnostic criteria of hypertensive in pregnancy. So, what are the definitions and diagnostic criteria there? I will go through. And next will be ICU management of eclampsia. Next, please. So, coming to diagnostic criteria, next, sir. So, gestational hypertension. So, it defines as the hypertension without proteinuria or other signs and symptoms of preeclampsia related to organ dysfunction that develops after the 20 weeks of gestation in a patient with previously normal blood pressure. Next, please, sir. So in this slide, we can see like the blood pressure anything more than 140 or more than diastolic blood pressure more than 90, at least 2 occasions, 4 hours apart after 20 weeks of gestation in previously normotensive individual. And key part here is there is no proteinuria, no signs and symptoms of preeclampsia related to organ dysfunction. So that's the main thing. Next, sir. So what is a preeclampsia? Same as previous definition, except that here that we can see the proteinuria and end-organ dysfunction we can see. Next, please, sir. So here we could see the 7 points. So any one of the, if it is present means it is more towards the preeclampsia. So So 3 points you must remember. One thing is systolic blood pressure more than 140, diastolic blood pressure more than 90. This is first point. And second point is that at least 4 hours apart, it should be recorded, and it should be more than 20 weeks of gestation previously normotensive patient. And along with that, there must be a proteinuria or platelet count less than 1 lakh, serum creatinine more than 1.1. Transaminases, that is 2 times upper limit of normal, pulmonary edema, and new onset of headache that is not correlated by other diagnosis, and visual disturbances. So any one from these 7 symptoms is there means it is suggestive of preeclampsia. Next, please, sir. Next, sir. So in this, then what is preeclampsia severe feature is that the systolic blood pressure should be more than 160 and diastolic blood pressure more than 110, and at least 2 occasions 4 hours apart. Along with that, if there is any severe thrombocytopenia, impaired liver dysfunction, that is 2 times upper limit of acute kidney injury, and pulmonary edema. So here the difference is the blood pressure only. So if the blood pressure is more than 160 or systolic blood pressure and diastolic blood pressure is more than 110 means it is severe eclampsia. And other features are stable. Next, please, sir. So there are 2 subtypes in this classification itself. One is early, late. So early onset means anything which is less than 34 weeks. Of course, it is more than 20 weeks of gestation, but it is within 34 weeks of gestation. And anything after 34 weeks of gestation is considered as late onset. And other subtypes are HELLP syndrome, gestational hypertension, preeclampsia with or without fetal growth restriction. Next, sir. So coming to HELLP syndrome, it is a subtype of preeclampsia with severe features like it has hemolysis, elevated liver enzyme, thrombocytopenia, other predominant features. So hypertension, CNS dysfunction, or renal dysfunction may be present. So this we will be dealing it for the upcoming slides. Next, sir. So then what is eclampsia? It is occurrence of tonic clonic seizure in a patient with preeclampsia in the absence of other neurological condition that could account for seizure. So in the absence of other neurological condition, if the patient has a background of hypertension, the pregnant patient more than 20 weeks of gestation, if the seizure occurs, means then it is termed as eclampsia. Yes, sir. So ISSSP classification system. Here there are 2 types. One is pre-pregnancy and pregnancy. So pre-pregnancy there are list of hypertension disorders, and pregnancy that is more than 20 weeks there are a list of hypertensive disorders. Next, sir. So in pre-pregnancy, it is white coat hypertension, which means that whenever the patient comes to the clinic, if the systolic blood pressure is more than 140 and diastolic blood pressure more than 90, it is called as white coat hypertension. But however, in home or in ambulatory BP monitoring, it is less than 135/85. Whereas opposite is masked hypertension, where the BP is less than 140/90 at clinic, but more than 135/85 in other than clinic. That is in during the ambulatory BP monitoring. In chronic hypertension, it is a hypertension detected pre-pregnancy or before the 20 weeks of gestation. That is long-term hypertensive patient. Next, please. So here the chronic pre-existing hypertension, that is a previous hypertension diagnosed before the pregnancy, at least 2 occasions before 20 weeks of gestation. So hypertension that is first diagnosed during the pregnancy and persists for at least 12 weeks postpartum is called as chronic hypertension. So there are 2 criteria here. One is before 20 weeks of gestation, that has 2 occasions. And other one thing is that continues after the 12 weeks of postpartum, also treated as chronic hypertension. So here the BP, again BP criteria is same as previous, more than 140/90. And here 2 stages are there. Stage 1 is systolic blood pressure between 130 to 120 pre-hypertension like. And stage 2 is systolic blood pressure more than 140 and diastolic more than 90. Next, sir. So there can be some, suppose there is a difference, like chronic hypertension patient with superimposed preeclampsia. In such cases, what happens is that if, there will be sudden increase in blood pressure in previously well controlled, or escalation of antihypertensive therapy to control blood pressure, or it can be a new onset proteinuria or sudden increase in proteinuria in patients with who have already has proteinuria before pregnancy, and significant end organ damage consistent with preeclampsia after 20 weeks of gestation. Next, sir. So These are the various points. So the same thing, except that here is it's with severe features. So previously the patient had hypertension. Suddenly what happens is that patient blood pressure has raised more than 160 bar 110. And in spite of on medication, along with that, if the patient has thrombocytopenia or altered liver function, particularly raised the transaminase at least 2 times of upper limit of normal, and new onset worsening of renal insufficiency and pulmonary edema and persistent visual disturbance. So any one feature along with this finding of elements, it implies the chronic hypertension superimposed preeclampsia. Next, sir. So in pregnancy already, so first we saw before the pre-pregnancy. Now this is pregnancy classification. Here gestation hypertension and preeclampsia, which we have already seen previous slides. Next, please. So there's something called as seizure prophylaxis, which is mainly applicable in two conditions: preeclampsia without severe seizure. Seizure prophylaxis individualized, depends on the clinician who attend the case, like obstetrician. And magnesium sulfate is usually mandatory with preeclampsia with severe features to prevent the seizure. Next, please. So coming to the ICU management of eclampsia, so there are some key principles for management. So first is to maintain the airway patency and preventing aspiration, prevention of maternal hypoxia and trauma, and treatment of severe hypertension if it is present, and termination of seizure if necessary, and prevention of recurrent seizure and evaluation for delivery. Next, please, sir. So, when writing about the ICU management of eclampsia, it is very important to know the investigation, because complete blood count is very important. To help, we need anemia to check for anemia and thrombocytopenia. Variables here to see the features of hemolysis. LDS, it is one of the criteria to know the health syndrome, and coagulation profile to know the complication like DAC, and serum creatinine to assess the renal dysfunction, and liver function test to assess the transaminase level, and urine analysis to know about the proteinuria, and urine spot which also know to quantify the proteinuria. Next, please. So when do we, so eclampsia has seizure. So whether to take CT or MRI, that depends on this four conditions. Suppose the seizure is very persistent, because in preeclampsia, the seizure lasts for a few minutes and immediately it is self-limiting. Suppose the seizure is persisting, means definitely we should consider for alternate diagnosis. And if the patient has focal neurological signs, if there is seizure recurrence, then seizure after 24 hours after delivery. So these contribute to the other than other diagnosis of preeclampsia. So imaging is very mandatory. Next, sir. So coming to oxidation part, the patient should be comfortable lying in lateral legamentous position. Supplement oxygen should be given, and when the patient is in bed, the cradles side rails should be kept. Next, sir. So the treatment of hypertension, the threshold for initiating antihypertensive therapy is if the diastolic blood pressure is more than 110, or systolic blood pressure more than 160, on repeated measurement, definitely we should start the antihypertensive medication in the setting of eclampsia. So adolescent patient with an oral, usually having lower blood pressure, where we can start the treatment even at the lower blood pressure levels. Yes, sir. So what is our target for treating the blood pressure? This is systolic blood pressure. To maintain the blood pressure less than 160 or diastolic blood pressure less than 110. We should not drastically decrease the blood pressure too fast, because it can compromise the uteroplacental perfusion. Next, please, sir. So coming to the choice of antihypertensive, choice of antihypertensive labetalol, which 20 mg IV bolus is given and may be repeated every 20 minutes, or to reach the maximum cumulative dose of 300 mg. This is the bolus regimen. Other one is infusion, where we can start with the 20 mg bolus and we can start infusion at 1 to 2 mg per minute as infusion therapy. Another treatment option is hydrolysis therapy, where we given as 5 mg over 2 minutes and repeat after 20 minutes if the target BP is not reached. So maximum dose by which we can give is 20 to 30 mg. Next, sir. So other drugs is nicardipine. We start with 5 mg per hour infusion and we will be maximum to 15 mg per hour infusion, and dose can be titrated every 15 minutes. And other drug which is very commonly used is nifedipine. We start with the 10 mg initial doses and we titrate every according to the BP, which is recorded at 20 minutes. And if target BP not reached, means we'll give additional 10 mg. But maximum dose we can reach is 30 to 60 mg per day. And BP should be very cautiously monitored because it can drastically reduce the BP. So it should be carefully monitored. Next, sir. So coming to the anti-seizure medication, the most common drug which is used is magnesium sulfate prophylaxis, which has a loading dose of 4 to 6 gram over 20 minutes. So why we are preferring magnesium sulfate is there are many studies which showing that it benefits the fetal well-being also, as well as it reduces it acts on NMDA receptor basically and decreases the membrane excitability, and it also have mild uterine atonic activity also, which help to reduce the postpartum hemorrhage also. So since it has multiple benefits, we prefer magnesium sulfate for as anti-seizure prophylaxis. So loading dose is 4 to 6 gram over 20 minutes. This is one regimen named PICHA regimen. Another one is 5 gram over each buttock as a loading dose. This is a Zuspar regimen. So maintenance doses, when it is IV, it is 1 to 2 gram per hour infusion. Maintenance for 24 hours can be given. And if suppose if we are having the other intramuscular regimen, it is Zuspar regimen is for every 4 hours in 5 gram intramuscular is given. And therapeutic level we should monitor. We should target at the range between the 4.8 to 8.4 mg per deciliter. So next, if the patient is actively flowing seizure, definitely we should start the benzodiazepines. Next, sir. So coming to the fluid management, we should, which is very important because fluid balance should be optimally maintained. Because if it is not taken care of, the patient may land up in pulmonary edema. So usually we target a maintenance fluid of 80 ml per hour and preferably balanced salt solution. In the oligoria, due to volume contraction, respond to the modest fluid challenge. Like we can give for 250 to 500 ml bolus and assess for response. If no response is there, then we should think of any renal impairment. So adjust the maintenance infusion according to the volume of infusion medicine. Like we'll be giving some antibiotics or other medications. So those whichever we are giving as infusion, that should be adjusted. And diuretics should not be used unless there is a pulmonary edema. Next, please. So this is the flow chart for managing the seizure, eclampsia. So whenever the patient is admitted in ICU, place the mother in the left lateral position, maintain an open airway, use airway disease if needed, supplement oxygen 8 to 10 liter per minute, and establish the wide IV access. And patient must be protected. And if the seizure is not self-limiting, then we should consider starting the anti-seizure medication. So initially we can give lorazepam 4 mg IV, maximum 2 mg per minute. Repeat if needed after 3 minutes. Establish the IV access. Next, please, sir. So suppose if the seizure is resolving, then we can go ahead with magnesium sulfate therapy. Suppose if it is not resolving it, we should follow the protocol for the status epilepticus, which we all know. Suppose if the patient is second seizure there means on maintenance therapy, next please, sir. Then check for the magnesium level. If it is not achieved, means we can repeat for another bolus and again resume the maintenance infusion. Suppose if the third seizure happens, means we should start the anti-seizure medication like fosphenytoin or phenytoin. So it is better to avoid use the sodium valproate because it is not good for fetus. And one other thing is, so key takeaway from this flow chart is we can consider giving the 2 times bolus along with that infusion. If the patient is not controlled with magnesium sulfate first dose, we can consider repeating the second dose IV bolus, provided if we check the magnesium levels. Next, sir. So, as said before, most eclamptic seizures are self-limiting. Medications are administered to prevent the recurrence, and maintenance phase is given only if the patellar reflex are present and respiratory rate more than 12 and urine output more than 100 ml over 4 hours. Next, sir. So, supportive care, continuous fetal monitoring is in viable cases very important. Monitor urine output, reflexes, respiratory rate, electrolyte, and thromboprophylaxis is very much important. Next, sir. So, actually control 24 hours. Next. So, because of eclampsia, it can range from abrasion of placenta, DAC, pulmonary edema, acute renal failure, aspiration pneumonia, cardiopulmonary arrest, liver hemorrhage syndrome. So, we should not try to send a to reports. BP can be considered for discharge after 3 days once the BP started settling, and patient should be reviewed after the 7 days for follow. So that's a postpartum recurrence. Second course of seizure prophylaxis is followed if the patient has any seizure episode in the future. Definitely, we should give the consider giving the magnesium sulfate during the postpartum period. Next, sir. Thank you.
I think fine, particularly on the antihypertensive, both labetalol and nicardipine. A little emphasis on side effect profile and all others, and more fetal monitoring. Today we have almost very advanced way on fetal monitoring. Then delivery is also it's a therapy itself, and then fetal lung acuity delivery, those that we also lastly, I think magnesium, there are multiple protocols, but this is the most important protocol that I think, if I have not mistaken, Pritchard protocol is the
Yes,
name.
sir.
Pritchard and so this is the standard regarding recurrence of continuation of uh, pathophysiology is sometimes asked because this is an endothelial dysfunction sort of. So a little bit you should read a little bit on the pathophysiology itself of preeclampsia, because you would be definitely getting, in practice you will be getting a lot of patients because of higher age of elderly primaries and all others. Those are now come up. Lastly, follow up is a tricky. You have covered it up. I think uh, if you may add a couple of more points on that, it would be nice, particularly recurrence of seizures and all others. And post delivery eclampsia is also, I think, 25%, if I'm not mistaken, that this can happen on NA. So that part also has to be covered. Okay,
Okay, sir. Yes, sir. Yes.
Manoj, carry on. Next one.
Okay, sir. Manoj, next is this thing, no? Liver dysfunction pregnancy.
Liver dysfunctional pregnancy, sir. Yes, sir.
Okay. Is the screen open for you?
Yes, sir. Open, sir.
Okay, I'm started sharing. You can start.
Yes, sir. Next slide, sir. So topics I'm covering on this PPT is diagnostic criteria of HELP syndrome and comparison of HELP versus acute fatty liver of pregnancy, then viral hepatitis. Then we are going to see about the management of HELP. So these three are sub questions under this topic. Next, sir. So coming to the diagnostic criteria of HELP. So this is the Tennessee criteria. So here there's three components. One is hemolysis, and the other one is the platelet count and liver enzymes. So coming to hemolysis, this 5 parameters should definitely be there. One is peripheral smear, which is histiocytes, which shows the blood cells, serum bilirubin more than 1.2, and low serum haptoglobin. LDS more than 2 times the upper limit of normal, and severe anemia unrelated to the blood loss, not due to blood loss, co-linked with hemolysis. Next, sir. So liver enzymes, AST or ALT more than 2 times upper limit of normal, and platelet count less than 1 lakh. So if these three criteria are present, which they are definitely.
Manoj?
sorry, definitely is correlating to the health syndrome. So coming to there are two types of classification. One is Mississippi classification, where it count less than 50,000 is class 1, and AST ALT more than 70, LDS more than 600, and class 2 platelet count 50,000 to 1 lakh, AST or ALT more than 70, and LDS more than 600. But we don't prefer Mississippi classification, but we prefer Tennessee classification. And here, and the platelet count is less than 1 lakh, AST more than 70, and LDS 600. Next, sir. So, next one, previous slide, sir.
Yeah, okay.
So, coming to health versus AFLP. So, clinical features are like, clinical features are, so health syndrome. Here is usually common in third trimester. Third trimester, right upper quadrant pain will be there, nausea, vomiting, and signs of preeclampsia, and jaundice mild. In acute fatty liver of pregnancy, it usually occurs in late pregnancy. Here, the progressive nausea and vomiting, abdomen pain, lethargy, and jaundice is very common. Next, please, sir. So, in viral hepatitis can occur in any gestation age with prodromal symptoms followed by jaundice. Abdomen pain and pruritus may occur. Next, sir. Coming to health syndrome, there will be severe endothelial dysfunction with microangiopathic hemolysis with hepatic sinusoidal fibrin deposition and platelet transfusion. So this is primarily due to the severe endothelial dysfunction. Next. So ALP is due to the long-chain fatty acid oxidation defects and the accumulation of microvesicular fat in hepatocytes leading to liver cell failure. And viral hepatitis, direct hepatocellular injury by viral infection. Next. So, laboratory features of health syndrome, as said before, only 3 features. There will be a hemolysis, elevated liver enzyme, and platelet count less than 1 lakh per mm. Next. So, AFLP, whereas ALP, there will be moderate elevation of AST or liver enzyme, hyperbilirubinemia, usually bilirubin won't cross more than 5 milligram per deciliter. Hypoglycemia definitely will be there. Leukocytosis, coagulopathy, renal dysfunction, and microvascular steatosis. Bias will be shown. Next, sir. Viral hepatitis, very marked elevation of liver enzyme will be there, definitely more than thousands, and mixed bilirubin pattern, both direct and indirect will be there. Sir, can you please continue, sir? I have another.
What?
Is it, sir? Sir, please, sir. Please continue, sir. I have emergency here, sir.
Okay. So when it comes to management of HELP and AFLP, termination of pregnancy is the only choice. In case of viral hepatitis, it will be mainly supportive care in some terms of, and in some cases, we can think of using antivirals can be used. And so as already told you, with regards to the incidence of HELP syndrome, it's 1 in 1,000 patients, whereas in AFLP, the incidence around 1 in 7,000 to 16,000 patients. Whereas in viral hepatitis, it is always 1 in 1,000. Timing, HELP syndrome, 28 to 36 weeks. And with regards to the investigation part, mostly the values are AST, ALT values are less than 500. In case of AFLP, it is usually around the third trimester, and AST, ALT will be around thousands, less than thousands. In viral hepatitis, it can be variable. It can come from the first trimester to the third trimester, and the values of AST, ALT will be around between 5,000 3,000. So in addition to that, when you come to HELP syndrome, the features which you can see along with that, the patient might have features of hypertension, proteinuria, the features of malaise and abdomen pain can be there, thrombocytopenia can be there. But most importantly, the HELP syndrome will have normal PT and prothrombin times. And some cases, there will be a bilirubin level will be less than 2, and mostly it will be indirect. Whereas in AFLP, one of the most characteristic additional factors will be most of these patients will be present with hypoglycemia, jaundice will be there, and usually hypertension, proteinuria usually absent, and they have elevated PT and prothrombin and APTT times, and they sometimes there will be fatty infiltration on the liver when we are doing a liver biopsy. And when it comes to viral hepatitis, abnormal serology is the only way to diagnose this. And mostly the viral hepatitis, the bilirubin levels will be more than 5. So when it comes to the management HELP syndrome, usually early recognition and prompt stabilization are very important. At the earliest, tertiary care hospital referral is very important. And try to treat the hypertension, seizure prophylaxis, and think of management of the hepatic bleeding. Prompt delivery after stabilization should be carried out. And in addition to that, the management of DAC, pulmonary and acute kidney should be kept in mind whenever dealing with the patients of HELP syndrome. The investigations, what we'll be doing, the complete investigation should be done. In addition to that, the most important investigation will get be considered, and platelet transfusion may be indicated to prevent excessive bleeding if the platelet count is less than 20,000. These are the indications of a blood transfusion in a patient with HELLP syndrome. Should be 110. Try not to reduce it drastically, and the choice of hypertension can be used in. You can use the beta blockers labetalol. Initial dose can be 20 milligram bolus, and immediate can be repeated. The second drug of choice can be hydrolyzin, which will be 5 milligram over 2 minutes, and you can repeat every 2 minutes with the rate of range volume 5 mg every 2 minutes. Nicardipine, it's basically an infusion, 5 mg per hour is an infusion, and you can go up maximum to 15 milligram per hour. And nifedipine, immediately releasing nifedipine should be used, which will be 10 milligram initial doses. And patients with seizure prophylaxis, as I already discussed about the magnesium sulfate prophylaxis, the same doses what we follow Pritchard regime should be can be used in this kind of patients. One of the major cornerstone of therapy in HELLP syndrome is delivery. Delivery timing and mode is very important. If it is more than 34 weeks, immediate delivery should be considered once the patient is stabilized. And if it is less than 34 weeks, administered steroids, delay the delivery for 40 days after the last dose. And in case of any deterioration, immediate delivery is recommended. And vaginal delivery should be sought out if there is no contraindication. In case of emergency, better go for an LSCS. And try to, the target values will be maintain a platelet above more than 40,000 before vaginal delivery and more than 75,000 before an epidural or LSCS. And patients present with hepatic bleeding, hematoma, unruptured and non-expanding may be managed conservatively. But expanding or ruptured hematoma requires an operative management, which includes packing, drainaging, hepatic artery ligations, resection of the affected areas of the liver. You can consider percutaneous embolization of the hepatic artery is the first line of therapy in patients who are hemodynamically stable. If the patient is unstable, you think of other cause. The patient is stable, percutaneous embolization is the first line of therapy. And in patients with the intractable hemorrhage, despite this intervention, the patient is not responding. Administration of recombinant factor 7A can be successful, whereas a lot of case reports has come in. And the liver transplantation because of spontaneous hepatic rupture, acute liver failure has been life-saving. These are the various modalities of therapy in case of HELLP syndrome. And always keep in mind management DAC, pulmonary edema, and AK should be kept in mind and should be stabilized using standardized therapy. And when it comes to the postpartum care, potential indication for intensive care monitoring includes if there is an acute or actual liver rupture or threatened liver rupture or pulmonary hepatic failure, DAC, kidney injuries, massive blood transfusions given to the patient, transfusion-related acute lung injury or cardiac ischemia, cardiomyopathy should be considered. And try to repeat the test as I already repeat the blood tests every 12 hours till it becomes stabilized. If there is a platelet drop is happening or the LDH continues to rise after the postpartum day, then diagnosis other than HELLP should be considered, like a primary thrombotic myocarditis should be considered. So do not stick on to the diagnosis of HELLP syndrome even at the fourth postpartum day. Thank you so much. Sir?
Anything specific on the treatment of HELP itself, Vijay? Because most of the treatments are mostly your
Supportive.
symptomatics, organ support, and delivery.
Yes, sir.
All
Yes,
end
sir.
on that. Anything
Yes, sir.
specific on that? Like in other microangiopathic hemolysis, we do plasmapheresis and all others, right? IVIG, plasmapheresis and others. Anything specific on HELP?
No, sir, HELP syndrome we have not done, sir. Anything is there, sir? You have to tell me, sir. Anything on
And
this?
in regarding AFLP,
Hmm.
I think that is in Indian context, your liver dysfunction at the last trimester, there could be a differential question that can come.
Okay,
One
sir.
is AFLP, viral hepatitis, particularly hepatitis E, which
Yes, sir.
Dr. Sarina has worked a lot. Sorry, I'm not well.
Okay, sir.
So Dr. Sarina has worked a lot. It has got a high incidence, but obviously due to better hygiene and all others, the incidence has come down itself. So please read about that part also. viral hepatitis in pregnancy can come as an A, and indications for liver transplantations. Though there are no, I don't think I have come across any scoring or something. Standard rules apply on that part.
Okay, sir.
Anything, Raku? Anything you want to add? More or less, sir. Please carry on.
Okay, sir. So the last topic will be critical obstetric hemorrhage. Sir, shall I present, sir?
Yes, please. What happened to that guy, Manoj?
I don't know. He has got some emergency, just left, sir.
Oh, अच्छा अच्छा ठीक है. Okay, fair
वो
enough.
कई इसमें आप भी उसका उसने मुझे
That's
स्लाइड
how
दे दिया
our
सर, मैं
life
चाहता
is, huh?
हूँ. Yes, just sending it, sir. Yes, sir. Just a minute, sir.
I think AFLP also needs a little bit of criteria you can add in the presentation,
Okay.
right?
Yes, sir. Yes, sir.
So that
Yes,
would be
sir.
nice if we had done.
Yes, sir. Just I'm sharing the screen. Just a minute, sir. Is the screen visible, sir?
It's
Yes, sir.
incorrect.
Yes, sir. ठीक है, sir. So the topics covered will be major obstetric hemorrhage protocol as well as women trials. So it's a structured protocol for the management of major obstetric hemorrhage. Combines, there are three factors. One is preparedness, systematic assessment, and target intervention for the fortis, and timely blood product resuscitation. These are the four components of your obstetric hemorrhage. What do you mean by major obstetric hemorrhages? If it is defined as more than blood loss more than 4,000 ml with ongoing bleed, or blood loss of more than 1,500 ml to 2,000 ml, regardless of the ongoing bleed, and signs of shock due to blood losses, and patients are requiring more than 4 units of blood transfusion. These are the criteria to determine that the patient is having an obstetric hemorrhages. And how is the patient team and preparedness and activations? Always try to recognize and call for help. Maintain an obstetric crash chart with uterotonics, large bore IV catheters, blood product tubings, uterine balloon, tamponade devices, surgical kits. Always designate a rapid response team like obstetric anesthesia, ICU teams, nursing and blood bank, and if available, intervention radiology should be kept in ready to immediately manage. And sometimes embolize standardized communication tools and conduct a regular multidisciplinary. This is the most important aspect of managing obstetric hemorrhage, where your team should be prepared and kept ready. When it comes to the systematic assessment, the same thing. It goes to the primary survey, maintain an airway patterns should be maintained, and try to prepare for intubation if alternate metastasis or patients going for massive hemorrhage. Breathing is where administer 100% oxygen, monitor SpO2. Circulation is always try to establish the large bore IV cannulas, begin crystalloid infusions, continuous vital signs including heart rate, blood pressure, urine output. Place the patient in a modified tenable position to optimize the preloads. These are the systematic assessment. A massive transfusion protocol, which I already covered. And when it comes to obstetric, start with 4 to 6 units of RBCs. And if it is along with the FFP, it is 1:1 ratio with RBCs. And platelet should be 4 to 6 units of platelet transfusions. Cryo should be 2 pools. Always your target is HB should be more than 7 gram. Fibrinogen should be more than 2 gram. And try to manage a INR of less than 1.5. And investigations, it's include the usual investigations, including HP, hematocrit, coagulation profiles, fibrinogens, and DDMS, and always keep your typing and cross-matching ready. And in case sometimes the patient can present with fever, always try to get blood cultures. When it comes to the focus assessment, always perform a perineal, speculum, and bimanual examine to look for any retained products or laceration. This is a very important component. And always use your bedside ultrasound for looking for intra-abdominal fluid, pelvic scan for retained bodies to localize the bleeding. This comes in the secondary survey where you'll be doing a focus assessment. And the hemorrhage control is that I already told you about the 4T. One is your try to attain your uterine autonomy. There is a tone. Try by doing uterine massage, bimanual compression, uterotonics like oxytocin, ergometrin, carboprost can be used. Try to maintain second T is for tissue. Try to remove the retained products, either by doing a manual removal or by doing a surgical evacuation. Third is your trauma. If there is a laceration rupture, try to repair the tear, and laparotomy if you are suspecting a rupture has happened. And third is your thrombin. Try to correct the blood products. These 4 things should be kept in mind: tones, tissue, trauma, and thrombin. These are the orders in which you try to correct your obstetric hemorrhage. Surgical intervention can be anything starting with the intrauterine balloon tamponade, Beeline suturing, intrauterine artery ligation, internal iliac artery ligation, uterine artery embolization, etc. That is the reason when it comes to obstetric hemorrhage, the intervention radiologist should be always be kept ready and kept informed regarding this kind of cases. And combining with the monitoring, continuous monitoring of the vital signs, hourly urine output of more than 30 ml is essential, and frequent monitoring of HP, coagulation profile, and fibrinogen should be done, preferably every 6th hourly. And always do a documentation of the problems and debrief the families, record your what are the findings, what all the intervention has been done, and always provide psychological support for the family in case of obstetric hemorrhage, because they'll be having a lot of troubles with this thing. And with regards to consultation escalation, immediate OBG consult should be abstained. If they are not available, general surgeon's opinion should be obtained. No blood bank should be kept activated for massive transfusion protocol, and theater anesthesia team and intervention should be ready, as already told you. And transfer to higher center, and keep on communicating with regard to the status of the patients as well as the registration plan on the way to the referral centers. So conclusion, research evidence supports uterotonic usage, balloon transmission ratio, and intervention radiology as an effective component of your massive comprehensive hemorrhagic care. This is a very important thing about a woman trial, which is the World Maternal Antifibrinogen Trial, where tranexamic acid for the treatment of postpartum hemorrhage, an international randomized double-blind placebo control trial was done. So the clinical question which was asked is, thus early administration of tranexamic acid compared to the placebo reduced death from bleeding in patients with postpartum hemorrhage. It was a double-blinded randomized trial. Intention to treat analysis, sample size was around 20,000, and it was calculated to provide a sufficient power to detect an absolute mortality from 3% to 2.5%. That is 25% relative risk reduction at the level of the 5% significant level. It was done in 193 hospitals from 2010 to April 2016. And what are the inclusion populations for? Women age 16 and over 16 were with a clinical diagnosis of PPH after vaginal delivery or cesarean section. That was a clinical inclusion criteria. Type of delivery was 70% were vaginal, 20% were LSCS. The total number of patients was 20,060. Placenta delivery, fully delivered in 90% of cases. The estimated blood loss was between 500 to 1000 ml in 50% of cases, less than 1500 in 80% of the cases. So intervention, 10,000 of the patients received tranexamic acid, 1 gram, which was administered intravenously over 10 minutes, whereas the placebos received identical package and volume administered intravenously over the 10 minutes. Both the group, the bleeding continued after 13 minutes or stopped and restarted within 24 of the first dose. A second dose of steady drug was administered in both the groups. The primary outcome was composite endpoint of the death from all causes or hysterectomy within 42 days of randomization. There was no statistical difference. Second outcome was statistically significantly reduced in patients with tranexamic acid. And other subgroup of mortality was reduced by 2.3% versus 2.6% in the tranexamic group, but there was no statistical difference. The p-value was 0.16. When it comes to pulmonary embolism, organ failure, sepsis, there was no statistical difference. Other outcomes were no statistical difference in thromboembolic events, surgical intervention, complications, and quality of life measured using the UQ5 criteria. So the conclusion about the women trial is tranexamic acid, yes, definitely reduces the death due to bleeding in women with postpartum hemorrhage with no adverse effect. When used as a treatment for postpartum hemorrhage, tranexamic acid should be given as soon as possible after the bleeding onset. So the strength of the study was, it was a large multicenter international RCT. And one of the good things is ampoules and packaging was identical in appearance, prepared by independent pharmaceutical company. Correct masking and coding of the ampoules was checked by independent random testing. Only 33% of the patients were lost in the follow-up. This trial is registered with the clinical.eu. The weakness of the trial was sample size got increased by 5,000 patients during the study. And the study hypothesis was redefined or refined after comments of the study in light of the outcome of the finding from the crash 2 study. And the most important thing is no formal screening for the embolic complications, and perhaps this were missed, particularly as a follow-up was limited to hospital discharge around 42 days if they were still in hospital. So bottom line, tranexamic acid may be beneficial in reducing the risk of death due to PPH on the basis of it being a cheap with a good safety profile in this study. Consider giving tranexamic acid early in postpartum hemorrhage. Early resuscitation, management of coagulopathy, and surgical assistance, the source control are the most important point of intervention. Thank you, sir. Yes, sir.
So I think we added a couple of obstetric indication for Tranexa, the trial itself, a gist of woman trial itself in the group. This was very precise. And in fact, you have completed before time. Thank you. This is what we really wanted.
Okay,
That
sir.
very gist presentation, crisp gist presentation. I think your boys and girls did a wonderful job on that part under your guidance. And
Thank you, sir.
also Vidur is also here on that part. And I would request two things. One is that you sort of work on those presentations a little bit
Yes,
as we discussed,
yes,
and
sir.
then we'll share it. And I will also, you can connect with Raku itself, and
Yes.
another couple of 10, 12 questions which we have not covered here can also be given as must read or something, the topic itself, just the
Sure, sir.
topic.
Yes, sir. Yes, sir.
So that they have a more comprehensive, because we are not sure. We are discussing only for the paucity of time, this 10, 12 topics. But I would rather say that if the other topics are also given to them to cover it up, so they would be able to attend. And what we also do is that we also look into that the topics that we discussed and the topic that we recommended to read,
Yes,
we
sir.
will look into in the final exams, that what was our strike rate on that part.
Okay,
Okay.
sir. Yes, sir.
Okay, Vijay, thank
Thank
you.
you,
And
sir. Thank you, sir.
thank you, Vidur, and all of you three, Manoj,
Thank you,
Vinay,
sir.
and Pradeep.
So, Vinay and
Excellent
Pradeep, sir.
presentation, a nice start. So we don't have a class tomorrow. Then we'll again have 2 classes on Wednesday, Thursday, and maybe 1 class on Friday.
Sure, sir.
So we'll connect. And Vijay, and Vidur, my sincere request, please, whenever you get time, please join the proceedings.
Okay, sir.
Yes,
Yes, sir.
sir.
Because
Yes, sir.
later on, I want you guys to take it over. It is
Okay, sir. Done, sir.
eventually work on this. Okay?
Okay, sir. Yes, sir.
Chalo,
Done.
Yes,
chalo.
sir.
Okay.
Thank you,
Good
sir.
night, everyone.
Thank you, sir.
Thank
Good
you,
night.
sir.
Good night, sir.